Hi there, my name is Lauren Spaeth. I'm a third-year resident in Columbus, Ohio at Riverside Methodist Hospital. I'm here today with Dr. Steve Nissen. We are so fortunate to get to speak with him. Dr. Nissen, thank you for being here.
My pleasure. Always like speaking with this group.
Thank you. I just wanted to introduce Dr. Nissen to the group. He's a former president of the ACC, a current MACC as well, and then you're the chair of the Heart, Vascular, and Thoracic Institute, the C5 research group.
Yeah, actually, so I'm the chief academic officer of the Heart, Vascular, and Thoracic Institute, and I do look after our clinical trial center known as C5 Research.
Very good. That's a very impressive research group, and I'm very thankful we could talk about that today. Dr. Nissen is presenting on the SURPASS cardiovascular outcomes trial. I'd like to first talk about why is this trial important to have been completed in the scheme of all of our GLP-1s?
Well, first of all, there's been an evolution here. The first generation drugs were all GLP-1 agonists like Dulaglutide, Liraglutide, and Semaglutide. Tirzepatide came along around 2022, and it's a dual incretin. It is a agonist for both the GLP-1 receptor and the GIP receptor. And the question was, are there incremental benefits of targeting both receptors? SURPASS-CVOT was designed as a non-inferiority trial. And the reason that was done is that if you're going to compare to something, for FDA purposes, for regulatory purposes, you have to study something with a labeled benefit, and you have to study it using the same endpoint that trial did. And Rewind for Dulaglutide used cardiovascular death, MI, and stroke. When the trial was unblinded, it showed exactly what it was designed to show, which was non-inferiority. But it's not the whole story.
Right. And today you spoke about you talked about the primary outcome, but the secondary outcomes, the cardiorenal aspect of that.
Yeah.
Could you get into a little bit of that?
Well, we've known for some time, and I've worked closely with our bariatric surgeons in this area for quite a number of years. We've known that obesity and weight loss has many more effects than the three narrow components of CV, death, stroke, and MI. And so we adjudicated in the trial broader endpoints, not just those three, but we also looked at all-cause mortality, which doesn't need any adjudication, which is very good. Coronary revascularization, important outcome. Heart failure, and worsening of kidney function to the extent that of doubling of creatinine and other sorts of adverse renal outcomes. So we had 6 components. And what I did was a post hoc secondary analysis of the main trial, asking the question, if you look at the broad range of cardiorenal adverse effects, was there a difference between a dual incretin, Tirzepatide, and a monoagonist, Dulaglutide?
Right. And my understanding is it's the GIP component is unique to Tirzepatide, and it's reducing the adipose tissue that's kind of around the kidney. That might be one of the suggested mechanisms for improvement.
Yes, that's a good question. So both GLP and GIP agonists result in weight loss, but the dual incretin results in more weight loss. So it's a more effective obesity drug, and it lowers A1C by more. And so it's just a kind of a souped up version of these first generation drugs. But anytime you do that, you've got to ask the question, is it really better or is it not better?
Right.
And that was the question I was really asking.
Yes. Can you talk about the results that you found in the study?
So we looked at the 6 component outcomes that I talked with you about. The hazard ratio, now remember, this is the first active control trial of one of these incretin therapies. And we saw a hazard ratio of 0.84 with a p-value of less than 0.001 with a reduced event rate with Tirzepatide compared with Dulaglutide. We did sensitivity analyses where we took out the renal endpoint, just did 5 endpoints. Also superior, 0.86, p less than 0.001. We took out both the heart failure and the renal endpoint and just looked at the classical 4 endpoints, and it was superior. And in fact, I didn't show it here, but But if you just substitute all-cause mortality from cardiovascular death, there is a lower event rate with tirzepatide than dulaglutide. And so it shows us why it's so important to look broadly at the cardiometabolic effects of these drugs and not too narrowly.
Not too narrow. When you think about the landscape of where we're going with these therapies, retatrutide is, a triple agent. Is tirzepatide going to be the drug, or when you talk to us 5 years from now, is it going to be an even more advanced drug on top of that? I know there's a lot of trials at Cleveland Clinic, lots of different formulations of adding things in.
Well, we're looking at all kinds of things here. We're looking, first of all, we're not doing the retatrutide trial, but it will be done. It's being done by very good people. And it is a triple agonist. It adds glucagon to the mix and seems to produce even more weight loss, particularly in women, interestingly enough.
Okay.
And there was an outcome trial called Triumph with retatrutide. It's coming. It's well along. There's an oral agent called orforglipron, and we are doing one of those trials. My colleague, Dr. Luke Laffin, is studying orforglipron, which is a GLP-1 agonist that's an oral agent. And it's unlike oral semaglutide in that there's no food effect. So you can take it any time of the day, no food effect at all.
Right, you don't have to hold it for 30 minutes.
Yeah, and actually you really should hold it for an hour.
For an hour,
for semaglutide to get the full effect.
Okay.
So with orforglipron, there's no food effect. So that's coming. And so I think there's no end in this. Yeah. I lived through the era when we did one after another negative trial with obesity-related therapies. I did the study with bupropion naltrexone. It was awful. The sibutramine was taken off the market. Fen-phen caused valvular heart disease.
Right.
I mean, this was a miserable journey. And I feel really exhilarated for these patients.
Right.
And I think it's important for everybody to understand that obesity is a disease.
Yes.
It's not a lifestyle. Don't blame the patient. Blame their genes, but fix it. And if you can fix it, you can make people better. You can reduce their mortality as well as their morbidity, and you can change their life trajectory.
Definitely. When I was reviewing this study again, one of the limitations that it talked about is the patient that this is used for primary prevention. Are there studies ongoing that are talking about, the use of primary prevention in that diabetic patient? I was thinking about some of our PCSK9 inhibitors just, changing for primary prevention. How do you think about that?
I thought you'd never ask.
Oh.
So I'm the study chair for a trial known as SURMOUNT-MMO.
Okay.
SURMOUNT-MMO is studying tirzepatide in patients without diabetes, and both in primary and in secondary prevention.
Excellent.
With very large cohorts in both. It's 15,000 patients.
Wow.
Big trial. It's fully enrolled. It's in the follow-up phase. Stay tuned.
Excellent.
And we're going to tell you the answer because we'd rather obviously prevent the first event than the second event.
Definitely.
And so we're going to find out.
I'm looking forward to that. I'd like to ask you about Sir William Osler. He had quoted once that the young physician starts his career by using 20 drugs for multiple diseases. The old physician uses one drug for 20 diseases. Is this that drug?
Well, that's a really provocative question. We have seen so many benefits. Here we have a heart failure benefit, and we have a kidney benefit, and we have,
hepatic
benefit. Fatty liver disease gets better.
Right.
But I think these are all downstream consequences of what happens when you accumulate fat in the pericardium, fat in the renal sinus, fat in the liver. And so it all comes down to the ectopic deposition of fat that occurs with obesity. And so if you can treat that, you can treat a lot of different adverse effects.
It's a really exciting time to train. I'm really looking forward to the career ahead, and I'm happy to be here at ACC. Something that I admire about you quite a bit is your dedication to patient safety And I'd hope that you'd talk a little bit about what does that mean to you, and what does that mean in clinical trials that you're overseeing?
Well, first of all, sometimes you have to have a little courage.
Yes.
I've been down this pathway, and
Right.
really, when the cardiovascular outcome trials were not being done for any of these drugs. And we published a manuscript in 2007 where we found that rosiglitazone was increasing adverse cardiovascular outcomes.
Right.
We published it in the New England Journal, took a lot of heat, and people didn't want to hear it.
Right.
And my advice to young physicians is have the courage of your convictions, do the right thing, and publish negative results just as fast and as vigorously as you publish positive results.
Okay.
If you do that, you'll have a great career. And I really encourage our people to just move as quickly to publish things that didn't work as we do to things that do work. And I hope all of the fellows in training and others will do that.
Okay. Very good. The last question I'd like to ask you is about mentorship. At this point, do you have mentors still? Do you need mentors, or do you spend most of your time being a sponsor and a mentor to others?
Well, I'm at this stage of my career when I am mentoring many people, and you'll be interested to know that many of them are women. I think time has come for more women in leadership in clinical trials, and several of the trials I'm doing, in fact, the majority of them have women as principal investigator. I'm
Very
the
good.
study chair. They will be the first author, not me.
Good.
And there's nothing that I've done in my career that is as rewarding as watching a young person develop into their own and make a contribution to medicine. And interestingly enough, the principal investigator for the SURPASS-CVOT was Dr. Steve Nichols, who spent 8 years with me in Cleveland. And I'm very proud of his accomplishments, which are profound. And, now really good people, you just got to point them in the right direction and they'll take off from there. But still, it's important that somebody do that.
Right.
And I try.
Well, we appreciate you very much and your contributions to cardiology and your advocacy. You truly are a role model for the field, and I greatly appreciate you.
Thank you for saying that.
Thank you.